All right, welcome back, everybody. Welcome back to you all online. We're so happy that you are with us today and watching all the great things that we have happening. So we are fortunate to have Dr. Dolores Shoback back to us today, and she's going to talk to us virtually live. And reminder that she is from UCSF Health in San Francisco. So welcome back, Dr. Shoback.
Good afternoon, everyone. It's a real pleasure to be able to talk to you today. I really, really wish I were there in the room because that's always such a great energy. But I'm thrilled to be able to talk, so I'd like to go ahead and start my presentation now. So I get to talk to you about, I think, what's a pretty challenging topic, even for us who have been working with people with hypoparathyroidism for a long time, and that's calcium versus thyroid. When they're low, what's causing my symptoms? So I have nothing to disclose with respect to this topic and no conflicts of interest. So just a couple of quick facts about the parathyroid glands, and then we'll talk about the thyroid a little bit also. You know, because you have dealt with this disease for such a long time, that these are very tiny but very powerful little glands. Our bodies have 4 of them, and they're tucked right behind the thyroid, which makes them very intimately involved with each other all the way through. And this is just some facts about them. They're very tiny. You can see about 1,000th, 2,000th of an ounce in size for each one. And they only do one very, very critical thing in our bodies, and that's to make parathyroid hormone 1 to 84. And pretty much every single tissue, as you'll see shortly, in our bodies needs the effects of parathyroid hormone, mainly on the blood calcium, but some of the effects are through parathyroid hormone itself. And the main job of parathyroid hormone, as you all know, is to control the blood calcium through its effects on the bone and the kidney. But there are so many other tissues that care about PTH as well as the calcium level. So when there's not enough PTH in our bodies, hypoparathyroidism occurs. And what you're looking at is what we kind of often call the biochemical profile of the condition. Okay, the PTH levels are low, the calcium levels are low, the phosphorus levels tend to be high, bone turnover gets shut way down to a low level. And often because of our treatment for a hypopara, the urinary calcium levels go high often. So this is the biochemical profile that you all know so well, and that we often are looking very closely at when we see you in the office. We're looking at all those, hard pieces of evidence as to how things are going. But what we know from so much work that's gone on over many, many years is really what's shown here, that like all of the systems practically in the body are affected in hypoparathyroidism. And you can see in the top little green boxes where I've put the red stars, the central nervous system, that's our brain, of course, and the neuropsychiatric system, which is our brain and our minds, if you will. And then down in the lower left, the peripheral nervous system. These are all really important systems when it comes to the effects of a low blood calcium or a very low PTH level. And in the central nervous system, seizures can occur over the long haul. Calcifications can occur in the brain. There can be, on the neuropsychiatric side, there can be symptoms of anxiety or depression or other neuropsychiatric manifestations. We look down in the lower left corner, very important, and sometimes things that you feel every single day. The peripheral nervous system can be involved with what we call paresthesias. That means funny feelings, things that aren't normal, tingling, numbness. These are not normal things. And then muscle cramping and tetany. And then if we look at the other body systems that are listed on this slide, you can see that the heart can sometimes be involved, the lungs and the trachea can be involved, the kidneys, of course, and there's a lot on the kidneys at this particular meeting, so you don't need to dwell too much on the kidneys. but they are very importantly involved in the skin, of course, and the teeth. So really the entire body can be affected. So with all of that background, kind of the multi-system involvement affected by calcium and PTH, what are some of the symptoms? When I use the word symptom, I just want to remind you that I'm talking about what you will feel or what you will show. I'm not talking about something nebulous. It's something that you report to us. So the symptoms. One of those symptoms of a low blood calcium is tetany. And that means the muscles are irritable. And I've got some pictures to show you, and I think you could all tell us what that's like because so many of you have had that. A seizure, we mean there a fit or a convulsion, and there are several kinds that can occur when the blood calcium gets dangerously low, and we definitely consider that a very significant complication of hypocalcemia. I've mentioned anxiety, depression, poor memory, brain fog. These are all symptoms of effects of calcium on the brain and brain function. Then bronchospasm, which is an effect of a low blood calcium on the muscles within the lung and within the upper airways. So you can have wheezing and throat tightness, like laryngospasm is what we're talking about there. And you might feel a choking sensation in your throat. Then the muscle cramps, of course, which often go with the tetany, and then that numbness and tingling, particularly in the hands and the feet, around the mouth and in the lips. Those are areas that are particularly ones where those particular symptoms occur. And then the kidney function we've talked about. And then rarely does the heart get involved, but again, it often means it's a chronic problem and it's not being addressed by the treatment that people are getting. So those are the main symptoms of the low blood calcium and the due to hypopara. So as I said, I wanted to show you some pictures of tetany, and these are taken from the internet, so you can probably even find them if you do some searching. But tetany comes from the muscles being hyperexcitable, okay? And they're hyperexcitable because the nerves are stimulating them excessively, okay? And there are other reasons other than just calcium for tetany, but this is the main one that we're talking about today. And it's an involuntary contraction. Your fingers cramp up. The claw deformity or the claw-like hand that people get is a manifestation of tetany. And you can certainly see that in situations of low magnesium as well. So those are just some pictures of how the hand can appear when tetany is in place. So let's turn now to the thyroid, just some facts about the thyroid. You know that it is right in the same location as the parathyroids are, much, much bigger, as you can see. And its job is to make two hormones, T4, thyroxine, and T3, triiodothyronine. Important to realize that T4, that's the one that the thyroid makes the most of, is what we call a prohormone. In other words, all the tissues that use the thyroid hormones tend to make their own supply of T3, and that's the one that is most active in our tissues, okay? And in the thyroid gland makes some T3 directly, but most of it comes from the peripheral tissues. So this is just some additional physiology about how thyroid hormone is regulated in our bodies. And I wouldn't go into this if it weren't important, because many times we are confronted with measuring different hormones and assessing the thyroid status of a person. And the reason for that is illustrated here. So the things that control thyroid hormone production by our bodies, or that reflect how our bodies are or are not sufficient in thyroid hormone, is this hypothalamus pituitary thyroid axis. And as you can see up in the top, the hypothalamus, it's a part of the brain, and it produces a hormone called TRH or thyrotropin. And the other word for thyrotropin is TSH. produces thyrotropin releasing hormone, which travels down to the pituitary gland. They're right there in the same place, travels down to the pituitary gland and causes it to make TSH or thyrotropin. And the pituitary makes that, and then that goes to the thyroid and causes the production of thyroid hormones. And this production is very, very carefully regulated by the level of TSH in our bodies. And you can see those arrows that feed back on going back up from the thyroid to the pituitary and to the hypothalamus. So this is what we call a classic negative feedback loop. And the thyroid hormone that is produced by the thyroid gland or that you take in the form of pills feeds back on the pituitary. And the pituitary has a level of thyroid hormone production or thyroid hormone supplementation that it wants for your body. So it's a very, very good thermostat, if you will, of thyroid function. So if the T4 and the T3 levels are high and they're too high for your body, the TSH level is going to fall. That's negative feedback. It's going to lower those levels. If the T4 and the T3 levels are too low, then the TSH level is going to rise. So when we do those blood tests, looking at thyroid function, we are going to measure the T4 and we're going to measure the TSH, and they're going to be excellent indices of what your body wants your thyroid status to be. So this is how we tell what's, as I say in the bottom of this slide, what's normal in the right range for you. So what does thyroid hormone do in our bodies? It's got a huge number of functions. Nearly every tissue, I really think every tissue in the body is affected by the level of thyroid hormone. So very, very important as calcium is in our bodies. Thyroid hormone affects metabolism, it affects growth in childhood, it affects brain development in babies and children, and it has very specific effects on our heart, our muscle, our kidneys, our liver, our skin, everything's affected and responds to thyroid hormone. So it's critical that the level of thyroid hormone that you have in your bloodstream is good for all of these tissues. A few words about the heart, okay? Because sometimes when thyroid hormone levels are way out of line, you may be feeling some of these effects, and I want to bring those symptoms to your attention. So if there's too much thyroid hormone in the body, your blood pressure may go up. Your heart rate may go up. The force that your heart is contracting with when it beats may be stronger than it's capable or comfortable contracting with. So you may tire out. Even if this isn't addressed by someone, your heart could enlarge and even heart failure could occur. If the thyroid hormone level is too low, that may slow down the heart rate, may lower the blood pressure. And so we can pick up these things when we check your vital signs in the clinic. And even when thyroid hormone is at a low level, and it may go on for a long time, you can get heart failure from that. So it can be a confusing picture, but thyroid hormone is very important for the function of our heart. Lungs, it's really important as well because thyroid hormone can feed back on centers in the brain that control our breathing, so important there. And not only heart rate can go low, but respiratory rate can go low if thyroid hormone levels are too low. In addition, thyroid hormone regulates the motility of the intestine. And if the levels are too low, you may experience constipation from intestinal hypomotility, low motility. So it's important there as well. In addition, thyroid hormone is really important for the bone. It regulates sort of the overall metabolic activity of bone cells. And if the levels of thyroid hormone are too high, so the T4 level is too high, and then the TSH level gets suppressed, that's the picture we'd be looking at there. You may experience loss of bone mineral density. And this is really important, particularly in women who are after menopause, where bone loss from estrogen deficiency is a very important consideration. So we want to pay very close attention to what the thyroid hormone levels are in everyone, but also particularly in women who are postmenopausal. And so you may hear your doctor say, I don't want to, I want to make sure the thyroid hormone replacement is just right because it may contribute to osteoporosis. So that's where we're coming from with regard to that. It's very important for bone cell function. And then, along with what we said already about calcium and the brain and the muscle and the nerves, thyroid hormone is also really important there. If there's too much thyroid hormone in the bloodstream, the muscles can fatigue faster, you can feel weak, may have trouble getting up, may have trouble getting around and exercising. In terms of the nerves, thyroid hormone, if there's too much of it in the system, you may experience a tremor or jitteriness or hyperactivity. And then if there's too little, it's sluggishness and tiredness and muscle aching and things like that. So really, really important for nerve, muscle. And then in terms of the brain, if thyroid hormone levels are too low, for example, you may not feel as alert as you normally would, and as functional as you normally would. So very important for all of those functions. As I said, in childhood, very important for the growth of children, may affect brain development, and in women with too little thyroid hormone over time can have problems with their menstrual cycles, irregular periods, heavy bleeding, and sometimes difficulty getting pregnant. So very important for really literally every system in our body. So what are some of the symptoms that you might experience if your thyroid hormone levels are too low? Hypothyroidism, right? That's what we call that situation. So fatigue is one, tiredness, being sleepy, particularly like in the daytime, sleeping excessively, memory and concentration can be affected, weight gain can occur, the muscles are weak, we've talked about it, constipation because of the effects of inadequate thyroid hormone on the gut, dry skin and dry nails and dry hair. I didn't really mention that, but the hair and skin need thyroid hormone to be healthy as well. And then fluid retention. So there's quite a bit of symptoms that you could potentially experience because of low thyroid hormone levels. So now what I've done on this slide is I've tried to line up some of the most common symptoms on your left in the blue of hypothyroidism, and over here on the right of hypocalcemia. And you can see for fatigue, both situations can cause fatigue. For sleepiness, if someone is complaining of that, I'd be thinking more of a thyroid problem. Poor memory, poor concentration, brain fog, it really can be both. Okay, so we know, we can see already there's plenty of overlap and there's plenty of challenge for us and for you to distinguish what symptoms are coming from what problem, right? Weight gain, that's going to be more hypothyroidism. Muscle weakness, it's going to probably be either. Okay, constipation, mainly the thyroid, the dry skin, the hair, and the nails, mainly the thyroid, the fluid retention, mainly the thyroid. But then if you look on the right, when we started talking about tetany and muscle cramping and numbness and tingling, that we're going to lay at the doorstep of hypocalcemia and hypopara. So there's some overlap, as you can see, not that much, but there is some, and that overlap is important. But most of the time, when we kind of get to know you better and your symptoms better, can figure out which situation. And of course, we use the blood test to guide us in making those decisions. So when we're monitoring thyroid hormone replacement, I think the first question is always, how do you feel? Do you feel like your energy is up to par? Do you feel well? What's new with how you feel? And then I usually run through the symptoms of hypothyroidism or hyperthyroidism quickly, just to get a pulse on how my patient is feeling. And then we turn to the lab tests because those are going to be so very, very helpful. What is the free T4? Is it in the normal range? Is it where I want it to be? And where is the TSH, right? That important negative feedback loop is so critically important when we look at these lab tests. So I want that TSH to also be in the normal range. Now, I know some of you with a history of thyroid cancer have a different acceptable normal range. So we have to look at that in the context of your own situation, but we've got to look at both at the same time. And then I think the other important thing to remember is that if a small change is made, or even if a big change is made, you don't want to be doing lab tests for thyroid with, any faster than 4 to 6 weeks. So 6 weeks is sort of a sweet spot. And so you want to look at those lab tests because it takes a while for that whole negative feedback system that we talked about. It takes a while for that to, reset itself and give us blood tests that we can take action on and that we can rely on. So remember that about thyroid hormone. We're not going to be measuring it instantly a day or two after you make a change in the hormone. Now, we often get the question, why am I taking this particular amount, or do I need an adjustment in the amount of thyroid hormone that I'm taking? And you can see here, this is a table from a publication just telling us kind of a guidance, if you will, for how much thyroid hormone replacement people need. And so age is very important. And you can see with every single recommendation about thyroid hormone, we're looking at what the body weight is. And you can see in the middle, I've kind of highlighted the fact that for adults, we're looking at about 0.7 micrograms per pound or 1.5 micrograms per kilogram. That's the usual replacement. So if you've had a thyroidectomy, you're going to be thinking about, that particular range of thyroid hormone replacement. And then after that, it's fine tuning. Okay. And in older people, we lower the amount of replacement so we don't overstimulate often. And in pregnant women, we have to give more because of the needs change in pregnancy. So as you can see, there's lots of factors that go into it, and we need to be conscious of those factors, not just at age, not just weight, but all of the factors involved. And then, of course, we have the lab tests to guide us. Now, hypoparathyroidism, same kind of thing. You start with how you feel. And I usually start with the symptoms of hypocalcemia because those are really the scariest for you to experience. We want to know, are you experiencing those? The tetany, the muscle cramping, the numbness, the tingling. And then we go to the lab. Now here that we know calcium changes from moment to moment, so we're only going to get a snapshot of these lab tests, and they may not correlate with what you're experiencing at home or when you're exercising and so forth, but it's the best we can do at this point. And a good picture of the lab could involve really everything I've listed on this slide. But most of the time, we're looking at the calcium with an albumin and with a phosphorus to kind of determine, okay, have we got good control of the blood calcium level? And are these symptoms due to the fact that the calcium's, being run at a level that's too low? Now, different from thyroid, here, when we make a change, like we say, okay, you need to take a little bit more calcium in the middle of the day. When we make a dosage adjustment in either calcium or calcitriol or even PTH, if you're on that, we usually wait 1 or 2 weeks before checking the labs. You can do it more frequently if it's kind of an urgent situation, but in general, we're doing it fairly promptly after we make an adjustment because this is a much more dynamic system than the thyroid and needs to be checked more frequently or more close to the time when you make the change. So I just wanted to end with just some suggestions. I don't think I've resolved the challenges that it can be for you to decide what your symptoms are due to, and for us to decide often when we're trying to, get the best outcome and get you feeling at your best. But here are just some kind of general recommendations that I use all the time, and I call them tips to feeling your best. So I think number one, and maybe this is obvious, but I can't stress it enough, take the medications that you're taking on a regular basis and on schedule. Missing medications is just the beginning. It's the recipe for trouble. Okay. Remember to spread out the calcium you're taking so you can maximize the absorption. Taking, 3 grams of calcium once a day is just never going to work well. It's much, much better to spread it out over the course of the day if you can. You want to take your thyroxine, your T4 on an empty stomach, if that's at all possible, and then wait an hour before eating, again, if that's possible, just so that you can get good and consistent absorption of thyroid hormones. You want to take any supplements that you're taking, and you need to look at your supplements that have iron or calcium in them at times different from your thyroid, because you can get an interaction that lowers the amount of thyroid hormone that gets absorbed, and that can lead to lab tests that are troublesome and difficult and symptoms for you as well. Remember that some of the foods that we take in have calcium in them, like calcium fortified orange juice. You don't want to take your thyroid hormone with that kind of an orange juice, for example. And then same with antacids, okay, if you're taking those. And then if you're taking a high fiber diet, because that can actually affect calcium thyroid hormone absorption, you want to make sure that you just sort of be as consistent as you can about the fiber intake in your diet. And then I think one thing that's particularly important with regard to thyroid hormone is to look at the prescriptions when you get them refilled and make sure that the thyroid hormone that you're getting is the same generic brand. There are, I think, 6 different brands now for thyroid hormone, and you want to make sure that you're not getting switched around, because there can be differences in bioavailability with different preparations, generic preparations of thyroid hormone. So you can take a look at that, see which formulation you're getting, and make sure it's consistent, and ask your pharmacist not to make any switches, because sometimes that can happen without our even knowing about it. Okay, so stay with the same brand if you can. I think it's really important that, if you're experiencing symptoms at home that you're wondering, is it low calcium, is it low thyroid, mark down what's bothering you and bring those questions, bring those dates, and bring that to your medical appointment so that we can kind of try to work this out together. And then if you're taking any new medications or new supplements, bring those in, and bring in more pictures of the labels, for example, so that we can go over those and make sure there isn't something in that supplement that's affecting either your blood tests, and that's well known now, like supplements like biotin, for example, can definitely affect thyroid blood testing. And I think it's critically important to, if you're introducing something new into your medical regimen, to let your physician or healthcare provider know that. And so just the final things, we're in this together, we always are, and we want you to feel your best. So really, let's work together on making things work well for you and work much better. With that, I think that is my last slide.
All right, let's give it up for Dr. Shoback.
I'm going to take questions.
Thank you so much. And we're going to take some questions from the audience first. Bob, do you have the microphone? Okay. I think Bridget raised her hand.
Hi, Dr. Shoback. I got a question. Do you have a list of the types of seizures that we could have, the names of them by any chance?
That information is in a lot of the publications, and I would say right off the bat, you would be talking about kind of a seizure where you lose consciousness. We call that a generalized seizure, a grand mal seizure. You can also have what are called petit mal seizures, probably even focal seizures, where just one part of the body would shake or something like that. And probably even what is often called an absence seizure. So there's the potential for really any of the neurologic spectrum that are called seizures to take place. But those are the most common. And in one of the publications I mentioned to you yesterday, we have a very nice section of that on the neurologic manifestations. And so Patty and I are going to work on making sure that those papers get onto the website. So that would be a place to take a look at that if that's it.
Thank you, because they didn't have that information back in 2004, and I would say I had more of the shaking one, and at one point I had the more severe one when I was younger, but they didn't understand it then, so thank you, it just confirms.
Oh, Bob, over here.
So just to clarify, if you don't have a thyroid, you're still getting the TSH and the T4 every time that you get your thyroid checked?
Guilty as charged, I do. And the reason that I do that is that some of the time I wish I had it. Many doctors will just measure the TSH and say, okay, it's fine. And there's nothing really wrong with that. But about a half to a third of the time, you wish you had the free T4. And so I generally just get it. I have to be honest. But you could mostly use the TSH because it is such a precise barometer of what your body wants and needs, and skip the free T4.
Thank you. Michelle?
Yes. Have a patient has increased free T4, but an in-range TSH and no thyroid. What would cause this?
It would, I mean, since it's coming from the supplement, since the thyroid has been removed, what would cause it would be the amount of supplement that someone is taking. And it would say that that amount of thyroid hormone is okay with that person's pituitary gland. If you've made an adjustment more recently, for example, like, I mentioned how you want to wait that 6 weeks if you can after each adjustment. So like if you've up titrated, increased the amount of thyroid hormone, and the thyroid hormone level has gotten to a higher level perhaps than you want it to be, or outside the normal range, the TSH might not have caught up, if you will. So those would be two quick explanations for why that might happen. But I think over time, all of us use the TSH as the best indicator of what's going on with the individual and where the body is happy with the amount of TSH. Occasionally, you find that the TSH and the T4 are disconnected, and that could be situations where the pituitary gland is also involved. Remember the hypothalamus and the pituitary. That's really pretty rare. Most of the time, it's all going on in the thyroid and the pituitary by itself.
Thank you. Is there a relationship between your Synthroid dose and your calcium? In other words, when changing your Synthroid dose, does that impact the hypopara symptoms?
Ooh, what a good question. I would say generally no, because I'm hoping that you're not asking the question because someone has, severe hypothyroidism and untreated hypopara. When you get at the extremes of both of these conditions, treating one can certainly affect the other, when things are really out of line. But most of the time when you're making slight changes, you don't have to readjust the calcium, for example, because you're, lowering the thyroid hormone dosage or raising it a little bit. But of course, if it's a brand new situation and the calcium is very, very low and the thyroid is very, very low, you could certainly have an interaction there with the muscles and the heart and many other things. So you want to attack the situation, make things better with regard to the blood test, and then kind of reassess. But usually you're kind of able to adjust each one of these meds independently.
Okay. The next question is, have you seen patients that need to run slightly outside of normal levels on their TSH because they feel well at those levels, and when their TSH is normal, they have hypo symptoms?
Yes, I think I have. I have to be very careful in those situations about allowing that to happen, because kind of as we went through the different organ systems, you can see that over time, that could be a bad thing for body systems that don't, give us symptoms, like, for example, the bone. And so if a patient says to me, I feel so much better when my free T4 is 25% higher or 20% higher than the upper limit of normal, and my TSH is low, because even though you might feel better, that could have a detrimental effect on your bones. It could have an effect on the heart and cause atrial fibrillation. So we have to do our best to hold the line in those situations, because we know that some of the downstream consequences of running a high free T4, for example, even though you might feel better, it might be a regrettable situation if you go into atrial fibrillation, for example, or develop osteoporosis or worsen bone loss. So there are things that are silent until they become a problem. And so we have to be very careful and use the laboratory and work together on this, because we don't want those untoward side effects of over replacement, for example, or over supplementation to cause trouble down the line.
Okay, and I have
One
another
more.
question. There seems to be some disagreement on when to add T3. Do you have any recommendations?
I don't use a lot of T3. It's a big question that comes up. You're totally right. It's a good question. I don't use a lot of it. And I think many of us don't, because when you think about it, why does the body have a system where it converts T4 to T3? It's because, you know, the heart is smarter than we are. The liver is smarter than we are. The brain is smarter than we are. And they will make the amount of T3 that is healthy for those cells. And so we have to be careful. So when we give the T3 by itself, we are, avoiding all those important control points that our body has in place for regulating the amount that the heart sees and that the liver sees and so forth. So we do it with great care. Occasionally we do it, when people feel there's a gap, and so occasionally we do it, but with great care. So yes, it's a question. It comes up, and sometimes we do it with, as I said, with great care.
All right. Well, thank you so much, Dr. Shoback, for both of your presentations were amazing. Thank you.
Bye-bye now.